All right, good evening, everyone, and welcome to the Henry Schein Dental Academy webinar series. My name is Adam, and I'll be your moderator. I'd like to welcome back Dr. Stephanie Tran as our speaker, as she'll be reviewing how to diagnose and treatment plan cracked teeth and vertical root fractures. At any point during the webinar, we encourage your participation. If you have any questions, please feel free to type them into the Q&A section of your control panel, and we'll answer them live at the end of the presentation. And Henry Schein is not offering CE credit for viewing or attending this presentation, live or on demand. Dr. Tran, looking forward to it.
Hi, thank you so much again, Adam. And thank you so much to Henry Schein Dental Academy for having me take part in their webinar series again. So today I'm going to be discussing and demystifying cracked teeth and vertical root fractures and discussing their diagnosis and treatment planning. Because I know that cracked teeth, vertical root fractures, and especially whether or not a root canal treatment may be involved can be really hard to both understand, diagnose, and manage. So I'm going to be discussing today how to detect and diagnose cracked teeth and vertical root fractures, how to use Cbct especially to improve the diagnosis of them and improve the evaluation of the prognosis, and what are some of the techniques and considerations for management of cracked teeth. So a little bit about me. So I'm originally from Cupertino, California, but now I'm living in the hustling and bustling city of New York. I originally grew up in California, so I also did my dental school and undergrad education there, where I did the accelerated program at University of the Pacific. I did the accelerated 2+3 program, combined bachelor's and DDS. So after completing my DDS there, I had actually a very strong background in restorative dentistry, and I continued that in my GPR program at Stony Brook. So after working as a general dentist for a few years, which is where my restorative background came from, I realized that my passion was truly in endodontics. So then I went back to school and at the University of Tennessee, where I was chief resident and graduated with my certificate. And now I am an endodontist in the city, where I have an endodontic concierge private practice, both in the Hamptons and New York City itself. So I provide concierge specialty services for a number of practices. And I work very closely with my restorative dentists in that manner. In regards to cracks and fractures, these are some things that not only do I, of course, as a specialist, see all the time in endodontics, but we know, unfortunately, thanks to these unprecedented times and the COVID-19 pandemic, we are seeing cracks and fractures more than ever. We even had an article published in the New York Times, I think it was last November or October, something like that, last fall, where they had cited that this is essentially an epidemic. And we as practitioners see that a lot. So when we see all these cracks and fractures, how do we define them? A lot of times the names and classifications get used interchangeably or mistakenly. So this is just a really quick refresher on their diagnosis. There's going to be craze lines, which are mostly just in the enamel, and versus a true fracture. So like a fractured cusp is where the cusp is completely fractured through. So whereas like cracked teeth and split teeth are more extensive. Craze lines can be on marginal ridges. They can extend along buccal and lingual surfaces as well. And they generally are much more shallow. So there's often not necessarily pulpal involvement, but there can be depending on how deep they are. A fractured cusp, however, is a complete or incomplete fracture of the cusp itself. It starts from the coronal and then extends subgingivally. So oftentimes that like loses the entire wall of the coronal part. A cracked tooth, however, is when things start to get more involved. It's an incomplete fracture. It starts from the coronal, it extends subgingivally, and a lot of times it's mesiodistally, but it's not always. And it can extend through the marginal ridges, both subgingivally as well as internally and through the proximal surfaces themselves. So that internal extension is when pulpal involvement may be a consideration. And the prognosis is anywhere from questionable to fair, or poor, depending on the extent. It's all about the extent subgingivally and whether or not it can be restored, which I'm going to be discussing shortly. In terms of the extent internally, that's when pulpal involvement is considered, and that's when pulpal diagnosis is going to be really, really important. A split tooth is when a cracked tooth can progress to the point where it's involving either the tooth all the way down the root, starting from the coronal down the root, or also all the way across. That's when we're looking for things like a fracture through the pulp chamber floor, and that's when because the split is so deep, so far apically, the prognosis is poor. A vertical root fracture is a little different than a split tooth. So the difference between a split tooth and vertical root fracture is that the vertical root fracture starts at the root. So it's either apical up or mid-root, and both ways. So we can see in the diagram there that in this case, that it starts in the root. Because it involves the root, the prognosis is also quite poor. For an example of this too, so a friend of mine who's a surgeon sent me these pictures. So because I had diagnosed a tooth to have a poor prognosis, and to be in this case, we can see that it's a split tooth. So we could see that fracture in the clinical, like the actual extracted tooth, starting from the coronal and extending apically with, unfortunately, a lot of granulomatous tissue attached to it, because in this case, it was a split tooth and had a hopeless prognosis. So now that we know the classification, how do we diagnose their presence? So first, of course, is being able to see it. Magnification is of utmost importance. In endodontics, we use a microscope, but even high-powered loops are going to be very helpful. Another thing that can be helpful, so for example, if you're concerned that the magnification of the loops are not enough, an intraoral camera or intraoral photography are extremely helpful for those high-definition shots, and they give us so much more specific detail about the tooth itself. Additionally, transillumination, so how to see these fractures clinically, it's nice to have additional armamentarium. So in this case, transillumination is where you can use a light, either a transilluminating device or even something as simple as a bore light. So bore light is, you can find it on Amazon and other places, but it's actually this like little light. It's not very expensive, and it's meant to look into a gun, I guess. A colleague of mine is the one who suggested it to me. But the point is, it's a very, very focused little beam of light. You're focusing it on the tooth, and it helps diagnose fractures and cracks, because if there is a crack, it will stop the illumination of the light. So when you put the light against the tooth, as we can see in this picture, it will stop the path of the light. So you can see where the fracture is going. Additionally, dyeing the crack is also very helpful to visualize it. So in endodontics, we most commonly use methylene blue. The reason for that pigment in particular is because it has very, very tiny pigment molecule sizes. So it's to help diagnose very, very small fractures, but small cracks. But Caries indicating solution is often used in restorative dentistry and found to be very, very helpful in diagnosing cracks as well. And if you're in a pinch, even something as simple as a Thompson marking stick, like the little wooden sticks with the dye at the tip for dentures, even that is helpful if you're in a pinch, because what you're doing is you're trying to get the dye to go into the crack to help visualize it. The patient's symptoms are going to definitely give us clues as to the presence of a crack as well. So the patient may report biting or chewing tenderness, asking them whether they've had a history of a swelling, where the swelling is, and if they report like a bump on their gums. Additionally, sensitivity to asking the patient what they're sensitive to and what kind of things increase that sensitivity, so hot or cold, whether they're laying down or if it's happening at night. These are all different signs and symptoms that we can ask the patient to give us more clues. Asking the patient when it does have sensitivity, does it linger? Does it ache? Does it feel like it radiates somewhere? If it's spontaneous, or if it has to be a very specific thing, like it's only biting or chewing. And also, of course, the dental history. It's helpful. Patients are not always going to remember exactly, but having them give a ballpark of 5 to 10, or is it more than 15 or 20 years? That kind of thing can help us determine both the diagnosis and the prognosis. Additionally, when we're doing the clinical findings and evaluating the area, evaluating the existing restoration, what kind, how long it's been there, if there's caries, and especially the periodontal health around it. So evaluating the probing depth is going to be very important. Now, a deep probing depth is often mistaken as automatically meaning something. That in and of itself doesn't necessarily mean or define a crack, a vertical root fracture, that kind of thing, or a poor prognosis, because it depends on the kind of probing depth and what it's associated with. So is it a single narrow probing? Is it a wide pocket? How many there are there and where they are? So is it associated with a fracture visibly, clinically, like you can see the fracture that is associated with it or not? Is it in multiple areas? Does it involve bifurcation? And also evaluating the mobility of the tooth itself. Some things, of course, are much easier. So in this case, this patient, the bridge actually came off, so it was much easier to confirm the diagnosis. Although this case, it looks like, well, it's a J-shaped lesion, it automatically means a vertical root fracture. A lot of times, a very, very long-standing chronic abscess, a chronic apical abscess, can manifest itself in sinus tracts that come up the side of the tooth or a deep probing up the side of the tooth. So for example, in this case, on the mesial, it looks like there's that widened PDL or that periapical radiolucency goes up the mesial. That in and of itself does not confirm a vertical root fracture, but in this case, it was a combination of all the findings, which I'm going to be discussing shortly, like how we combine all these findings to determine what the diagnosis is. Also, with the bridge off, it was pretty easy to see that there was a fracture and gross caries. Additionally, the clinical findings of the mobility of the pieces, like the fractures themselves. So can you like get an explorer into a crack? Can the pieces of tooth move at the crack level? And sometimes you can't always clinically see it, but one thing to note if the crack is moving is whether fluid is coming through. So you can see fluid seeping into the crack and it starts to get wet, or if you had a dry canal and then or dry area and then you place something and it's wet again, that tells you that fluid is coming in through that crack. If a crack is large enough for fluid to get through, it generally has a poor prognosis. How stained the crack is as well. So if there's caries, is it very large or is it very, very deeply stained? A lot of times it'll be stained not just due to caries, but due to amalgam and metallic restorations. So you can actually see the extent of the crack and how involved it could be. And if these teeth are associated with swelling or sinus tracts or a perilous. Other testing of the tooth itself can help give us clues as to the presence of a crack or vertical root fracture. So percussion and palpation testing and a bite test will evaluate the periodontal ligament and the inflammation around it. So if there's percussion or palpation testing, where that palpation testing is there lateral pain or just occlusal pain? For the bite itself, it's going to be important to localize it. So the most helpful thing is like a tooth sleuth or bite or occlusal bite stick. Those really large wooden, like I think they're made of bamboo or something like that. But anyway, those larger sticks to have a patient bite on are not always the most helpful for diagnosing a crack or vertical root fracture, because it's very hard to localize exactly where it is. Is it on the buccal or lingual, or if it's on the specific cusp? It's nice to have something like a tooth sleuth or a bite like testing instrument, because it has a little divot that you that the cusp goes into, and you can localize it. One thing you're going to be looking for is whether there's pain upon biting initial pressure and then pain when there's biting on the release, because it's telling you when it's flexing and when that pain is being caused by the flexing. But something even as simple as a cotton tipped applicator can help, because at least a cotton tipped applicator is much smaller. So if you don't have a tooth sleuth in the moment, that can work in a pinch. And at least it can tell you whether it's like mesial or distal or buccal or lingual. And then for cold and hot testing, the heat testing is usually done with warmed gutta percha or something like that. It's very hard to like localize like a heat tip area. I mean, you can, but it can damage the pulp. And for cold testing, it's always done with a cotton pellet, never a cotton tipped applicator, because the wood in the cotton tipped applicator doesn't hold enough the cold. So the testing is not accurate. And please don't use ice sticks either. So let's say you can see the fracture. If we're looking at the fracture itself, what we want to do is evaluate the extent. If it's mesial to distal, like it's connecting completely, if it's only on one side or the other, or on the buccal or lingual, if it extends cervically, as well as how far it extends internally, that often can correspond with whether or not there's pulpal involvement itself. Additionally, the location and the number of fractures and cracks are going to be really important to try to find. So unfortunately, we see a lot of teeth that have older metal restorations having a lot of crazed lines and cracks. Evaluating exactly how extensive they are is going to be important to confirm the diagnosis. The periodontal involvement of the crack itself is going to be evaluated by how deep the probing depth is, and is there a probing depth even associated with it. So if it's normal, or if it's more than 6 millimeters, or if it's a very, very deep probing, like probing to the apex of 12 millimeters or more, and where and how many of them there are. So generally, if there are multiple deep probings, so like multiple probings to the apex, it's a poor prognosis. If there is a very, very wide periodontal pocket that is to the apex, that also has a often a poor prognosis, but it has to be in conjunction with like the other findings, not just the probing depth itself. And then on the restorative end is whether or not the tooth is even restorable. So how extensive that crack is, if the cusp is completely fractured subgingivally to the point where it's non-restorable, that kind of thing. And if those cracks are stained, if there's deep caries, and if the pieces themselves are mobile. So when we look at it from a radiographic standpoint, a lot of times there's a misunderstanding that a J-shaped lesion is always a vertical root fracture or always a cracked tooth. The biggest thing to take away from today is, please, J-shaped lesions are not always a poor prognosis. It does not always mean a vertical root fracture, because it can be even just due to the radiographic angle. If a lateral canal is also involved, it can mean that's just a sulcular sinus tract. It can mean a lot of things. It could mean perio versus endo, that kind of thing. It's going to be important to put all the findings together. What we're looking for on those radiographs, though, is where the bone loss is. Is there a widened PDL at a particular spot? Like, is it involving the entire side of the tooth or just in the apical area? Bone loss, like vertical bone loss in one particular area from the alveolar ridge down, and is that associated with, like, for example, a fracture line that we can see clinically? And then if there's any furcation involvement, so how much bone, if there's bone loss there, and how much, and of course we're looking on the radiograph to see what kind of ferrule there is. So what about with Cvcts though? So with Cvcts, for endodontic treatment, it's going to be important to try to use a limited field of view preferably. The reason for this is because a limited field of view gives us basically a high definition, zoomed in picture of the tooth itself. Why is that important? Because when it's specifically a smaller field of view, there are fewer anatomical structures that can cause interferences. Additionally, the voxel sizes are smaller, so the resolution is much better, so you can get a clearer view, just like how we can see a better view in high resolution digital radiography. Additionally, with the limited field of view, it helps us focus and gives us the better resolution to even be able to see all the structures from an endodontic standpoint. So whether or not the root canal filling material is close to a wall, if there is a missed canal, for example, in this particular CBCT, we can see that there's a missed MB2 and where it is. And what we're looking for from a cracked or vertical root fracture standpoint is the bone loss as well. So we're looking for the lesion, its extent, and how far up the tooth, how much bone loss there is. Does it involve other anatomical structures or vital structures? The extent, the width, whether or not there's a bony plate involved and a bony collar left, and the root canal itself. So if there are any issues with it, if it's off-centered, that kind of thing. So a question I often get asked is, even at the highest resolution CBCT, and it's a beautiful limited field of view, can I see a fracture every single time? No. So a fracture is very difficult to visualize, even on the highest resolution CBCTs. And the reason is because a fracture has to be a certain width, it has to be open to a certain amount to even be visualized. And that's without root canal filling material. Unfortunately, if there is root canal material, it makes it even harder, and that's because of beam hardening. So we can see from the little arrows here, the little white kind of streaks on that CBCT. So this is a patient of mine, the little white streaks and then the little dark streaks in between the white streaks, that tells us that is a beam hardening. So what it is just like the root canal filling material, which is radio opaque, causing the visual interferences. So when a CBCT beam hits the radio opaque material, that's what it looks like. So the problem with these interferences, these beam hardening interferences, are that it's very hard to actually see the little black line of a fracture. Sometimes the radio opacity of the beam hardening can cover it, or it can make it look like the little black streak is a fracture. So it's going to be really, really important not to just rely on the CBCT alone. It's about what the CBCT says that can tell us whether or not there's a fracture or crack. So if there is bone loss in the area of question, if there is a root canal filling material that's a little too close to the wall of the root, then and that is in the same spot as severe bone loss, then that would make us be more that in conjunction with clinical findings and the patient's symptoms can help us diagnose that there could be a fracture or a crack. So and then the other thing is, when you're using a CBCT to look for a fracture or a crack, we can't officially diagnose a crack or a fracture unless it's visually seen. So either surgically, clinically, on a CBCT. Those are the golden standards to officially determine that there is a crack or vertical root fracture. A lot of times, if we can't physically see that crack or vertical root fracture, then it's going to be confirming or consistent with the presence of one based on all the findings, including the CBCT findings. So that's going to be like that small like diagnostic specifics. So again, the thing to keep in mind is, even if you see a J-shaped lesion on a CBCT, that does not mean it's pathognomonic for a vertical root fracture or a split tooth. It has to be in conjunction with a bunch of other findings or visually seen, the crack or split tooth or vertical root fracture itself. So please just don't condemn teeth just because there's a J-shaped lesion. We want to see why there's a J-shaped lesion. So when we're using that CBCT in diagnosis, because it's so complex, I'm going to go through some case of like how I evaluate the CBCT itself. So in this case, this patient presented to me with biting and chewing tenderness, and that like the back of her gums felt like they were swollen, and that swelling would kind of come and go. So in this case, she didn't have extraoral swelling itself. We could see that this tooth had clinically some swelling in the palatal gingival marginal area, no sinus tracts specifically, but there was a deep probing on the palatal root that was 12 plus millimeters. So it's a probing to the apex. From a 2D radiograph standpoint, we can see that there was misanatomy in the mesial buccal, so it was never treated, and that this tooth had a crown, it has a root canal, and we can see a periapical radiolucency, but we can't necessarily visualize the fracture in and of itself. However, I do want to evaluate the existing root canal treatment and see what it could be, why she was having that deep probing. So the deep probing itself did not tell me that there was a crack or vertical root fracture. The deep probing told me, well, it could be maybe just a really large lesion that's extending up, but we want to take a look. So here we can see in the Cbct, so I took a low limited field of view of that area, that we could see a few things. That deep probing was associated with almost complete bone loss of the palatal bony plates. And we can see that there's also bone loss that extends all the way up on the buccal side of the palatal root. And then unfortunately, we can also see that not only is there that bone loss, but you can kind of see that fracture on the buccal side of the palatal root. And that fracture is consistent, that vertical root fracture is consistent on the other slices as well. And it's not really clear from the cross sections of the tooth because of that beam hardening again, but you can kind of see that in conjunction with where the bone loss is. And so that helped me confirm it. So it's the patients biting with their deep probing, the biting pain and the signs and symptoms, and the deep probing, and that deep probing combined with the bone loss on both sides, and the bone loss in multiple areas across this tooth. So we can see here, that's where I was looking for that fracture. And we can see that from multiple angles. Those multiple angles, the multiple areas of bone loss and that deep probing and the patient symptoms all helped me confirm that it was consistent with a vertical root fracture. So that's what I was looking for specifically in that Cbct to help me confirm the diagnosis, and we recommend it for an extraction. This kind of thing, and by having the Cbct, it's really helpful, so that way the patient doesn't have to go through invasive treatment, and then I can see the vertical root fracture clinically, but then I had to like remove core buildup, go through a crown, all that stuff just to diagnose it. So Cbct helps me do it much more conservatively. This was another case where I was looking for the possibility of a vertical root fracture. So this patient presented to me with severe pain in the lower right. She told me that this root canal had been done 17 years ago. And in this case, this patient didn't have that as many clinical signs. No deep probings, no swelling, no sinus tracts, no severe like localized areas of inflammation or perilous. The crown itself was beautiful, intact. No caries. So what could it be? From the two-dimensional radiograph, which looked exactly like the bottom left picture, that 2D radiograph looked exactly the same. So it was a widened PDL on the mesial of this tooth, a localized periapical radiolucency in the apical portion, but not involving the apex itself. So a lot of times with endodontically involved periapical radiolucencies, the round part of the radiolucency is going to be more centered on the apex. Not always if there is a lateral canal, but it should involve the apex. In this case, it doesn't involve the apex much at all. Additionally, I could see little light black streaks on the mesial of this tooth. So we can see here, there's that widened PDL, that periapical radiolucency, and then the little black streaks are these little things. Now, those were really faint, but when I put the slice directly in the area of those streaks, that corresponded with the those little black lines. So what you're doing is you're looking at it from multiple dimensions, so that we want to see the things correlate. So if I can see something from one view, that same thing should correspond from a different view, and that's what made me suspect that there was a fracture. That also makes sense because that's exactly where the widened PDL is, that's exactly where the start of this periapical radiolucency area was localized, and it was in the mid-root area. So that's what helped me evaluate for a vertical root fracture in this case. So due to all these findings, that's when I recommended for extraction of this tooth as well, because of the poor prognosis. So for a tooth like this, some things that would unfortunately make the patient a little bit more prone to a fracture is the fact that it's a second molar. That's another key factor. The further back the tooth is, or if it's like a terminal tooth or next to an edentulous space, that will make, as we know, it will make a tooth more prone to having a fracture or crack as well. And that's because if it's more terminal, then it's closer to the jaw, it's closer to the TMJ, and it then goes through more force because it's closer to that, the force of the lever, and then the joint. And then additionally, if it's against a edentulous space, a tooth that is either terminal or adjacent to an edentulous area is going to go through more force. So when it goes through more force, especially a smaller, if it's a smaller tooth or like a premolar, then it's also going to be more prone to cracking or having a fracture as well. So the next case was a particularly interesting one because I was also evaluating for a fracture, but there was a little bit of a surprise, which we're going to see shortly. So first off, how did I evaluate the diagnosis? Already, because like I said, it's next to an edentulous space, it's the most terminal tooth, I was already having some suspicions on this tooth. I was sniffing some questionable situations on this tooth. This patient presented with pain in the lower left. They told me that this root canal and the crown had been done like over 10 years ago. The tooth itself had some pretty good findings though. No large swellings, no sinus tracts, no deep probing depths of like 12 millimeters. There was a little bit of a furcation involvement, so maybe like a 6 millimeter pocket or like 5 on the furcation area. But that's like with some really firm probing. And then with the findings, this patient had percussion and palpation tenderness, but not severe biting pain. So we took a Cbct to evaluate for a few things, not just to see the fracture, but to evaluate the bone loss, to evaluate the pattern of the bone loss, and to look at the root canal treatment itself. Just from a 2D standpoint, the root canal treatment doesn't look severe, but my biggest concern was the post. Having a post there is not an issue, but it's how involved that post is. So we're looking at the 2D radiograph, comparing it to the Cbct. So this limited field of view, we could see that the post is okay, maybe kind of close to the wall, to the mesial portion of the distal root of this molar. But there's no perforations, no clear, obvious issues. We can see from other slices that this post is not like excessively enormous. But what are we looking for in terms of the bone loss? So the bone loss, there's a little bit of furcation bone loss. Okay, that makes sense with that like 5 millimeter, 6 millimeter probing on the furcation area. There's also periapical radiolucency. We can see that's close to the inferior alveolar nerve, but separate. And there's a couple areas of radiolucency. So one in the furcation area, which we can see here, a slightly separate one here in the apical area, and then possibly in the mid-root as well. So definitely a guarded prognosis on this tooth. This didn't confirm a vertical root fracture due to, I didn't see any severe bone loss up one side of the tooth. The furcation bone loss didn't extend all the way to the apex, so that didn't tell me that there was some sort of root fracture. And the apical periapical radiolucency was fairly centered around the apex itself. The root canal filling material was pretty centered in the mesial, didn't involve the sides of the root, and the post itself didn't go completely bust through the root, so it looked like it was doing okay. The main issue with the distal was that the root canal filling material was slightly off-centered, so that looked like it wasn't a full missed canal in the distal, but it was missed anatomy, so like a fin or the other side of a oval shaped canal. So if part of a canal is not treated, it can still harbor a lot of debris and bacteria. So I discussed this with my restorative dentist that, okay, there's a guarded prognosis because it could be a vertical root fracture, but it's not very clear. The problem was that this patient really wanted to save their tooth. The restorative dentist also really wanted to maintain this tooth because it was, it's the terminal tooth. It's an important restorative tooth. They're already placing the implant in the edentulous space. They would prefer not to have to do two if they could avoid it. So what we discussed was, because I couldn't visually confirm a fracture, I would do the root canal retreatment and evaluate for healing. And we're going to see if we could maintain this tooth. So when I'm evaluating for whether or not this tooth can be maintained, some of the prognostic considerations are not only knowing the survival, but how involved the tooth is. Now, cracked teeth in and of themselves does not deem a tooth. It does not determine that the tooth is completely non-restorable. There have been a number of papers that have shown long-term tooth survival, some at 60 months, some at shorter months. You can have a high survival rate of 84, 88 if it was an incomplete fracture. For teeth that had root canal filling materials, it was 85.5, seen in a 2006 paper, or even in teeth that have a cracked tooth that had reversible pulpitis. Sometimes the teeth stay alive even after a few years. In this case, there was one paper that said it was about 20% that ended up needing root canal treatment. So having a crack doesn't necessarily mean that the tooth has to be determined to have a poor prognosis. So how do we determine when it does? So when I'm looking at a Cbct, one thing I'm looking for is how involved that root canal treatment is, how large it is, how much of the tooth structure has already been lost, the kind of post and the position of the post itself, and whether there are any endodontic mishaps present, and how much bone loss there is. So we talked about like if there's a fracture itself and how extensive it is. And then the root canal treatment, for example, in this case, this root canal treatment was so large, it completely involved the side of the root as well. And that was corresponding to a lot of the bone loss on this mesobuccal root that unfortunately would have a poor prognosis. However, if a root canal treatment is fairly centered, it looks like it doesn't involve extensive amounts of tooth structure, then it will have a better prognosis. Patient considerations can also affect the prognosis, as we know. So the patient's medical history can determine whether or not their healing capabilities, whether or not they're candidates for an implant, or even if it's a contraindication for some sort of treatment. The restorative considerations, so how much tooth structure there is, as well as what is the overarching treatment plan. I really like to ask my restorative dentist what their treatment plan is for the tooth to help me confirm to help me make my treatment plan, and the patient's oral health. One of the things, especially with the COVID-19 pandemic, we know that because patients are often having so much anxiety, there's been an increase in bruxism, an increase in clenching and grinding, and malocclusion, and also an increase of caries, delayed treatment, that kind of thing. Though all those things can affect the overall prognosis, as well as the patient's expectations and their tolerance. So especially when something has a slightly guarded or questionable prognosis, such as a cracked tooth, letting the patient know ahead of time and evaluating the patient's expectations and making sure the expectations are all on the same page is going to be really important. Certain patients will tolerate a more questionable prognosis. Some patients may not, and that can help you with your treatment planning. And then what about whether or not we have to do the endodontic retreatment? So sometimes I get I often get questions and misunderstandings about what can be retreated. So if there is an existing root canal treatment, even if it's a post, a silver point, a cast post, whatever it is, the presence of the type of root canal treatment there is doesn't really affect the prognosis. It's about how big that root canal treatment is and how much tooth structure loss there is. So even if there's a large lesion, that doesn't necessarily affect the prognosis. It can still be retreated. Silver points can be retreated. Giant posts can be retreated, even posts that are really, really, really deep. Yes, removing a post can have a slightly increased risk of a vertical root fracture or excessive tooth structure loss that can make the tooth have a poor prognosis. But the post in and of itself does not make it a poor prognosis. It's if the post was poorly placed or involving too much tooth structure, that's when it can affect the prognosis. So in like these cases where, yes, these patients had posts that were larger or a bit longer, they're still able to be removed and still allow the patient to have a good prognosis and maintain their tooth. So the presence of the post itself does not affect it. Even if it's a gigantic cast post, it still can be removed, and that in and of itself does not affect the prognosis. So what about if a tooth has a crack? How do we manage that then? So one of the things that we as an endodontist can do is to make sure we can do more restoratively driven endodontic treatment. I know the buzzword lately is like a conservative endodontic treatment or minimally invasive, but the importance is that we want it to be in line with modern restorative treatment and in line with what our restorative colleagues are currently treatment planning. So that's why it's better to understand it as restoratively driven endodontic treatment. So what that means is more conservative accesses when possible, maybe making the access more of a caries driven or restoratively driven, so restoration driven, so aiming it at where the caries is or centering it where the existing restoration and existing tooth structure loss is going to be a better result to try to save as much tooth structure as possible. And then evaluating the tooth itself and how it reacts to endodontic treatment can help us evaluate the overall prognosis itself. So let's say you've done everything possible to try to be as minimally invasive, but you're not 100% sure if there's a vertical root fracture. So this is the same patient I was talking about earlier, where I couldn't see a vertical root fracture clinically or on the Cbct. And the Cbct, yes, there were areas of the furcation involvement and some bone loss in the apical area, but it was not like severe bone loss where an entire bony plate was gone. So it had a questionable prognosis, and I could not rule out a vertical root fracture. Because the patient and the restorative dentist in this case really wanted to maintain this tooth as much as possible, what I explained to the patient is that we would do this in 2 visits. So what I look for in managing these kinds of cases is that the 2 visits helps me determine if there is healing, and if there's at least soft tissue healing, then the prognosis may be more positive than we think, and that it may not necessarily completely deny a vertical root fracture, but at least it tells me that it's a better prognosis. So if it's a true vertical root fracture, then the soft tissue is not going to heal even after even after multiple visits with calcium hydroxide. Or if it just overall has a poor healing, the lesion is too large, something like that, and I don't see the sinus tract or the deep probing healing at all, then I would have a bigger concern about the overall prognosis. So for example, in this case, we had discussed that this patient came in symptomatic, did not have any sinus tracts, but did have a little bit of that furcation involvement. They wanted to maintain it, so I did it in 2 visits. So at the first visit, after looking at the Cbct and seeing where the bone loss was, what I wanted to see was whether or not if calcium hydroxide went into those areas of bone loss. So I removed that post. It was a big one. I then placed calcium hydroxide. The radiograph in the bottom right is actually not the root canal filling material, that's calcium hydroxide. So I placed calcium hydroxide for 2 reasons. One was to see if the calcium hydroxide flowed anywhere else. If it flows into really unusual areas like the furcation involvement or like out like down the side of the tooth, that would make me more concerned about a vertical root fracture. If it like puffs out just like one little spot, maybe it tells me that a J-shaped lesion is actually a lateral canal. So that's why calcium hydroxide visualization can be helpful. Some people even do the Cbct with the calcium hydroxide in to see how far it goes, or to see if it involves like too much of the tooth structure or something like that. It depends on how comfortable you are with how many Cbcts you want to take. Anyway, in this case, after placing the calcium hydroxide at the first visit, at the second visit, this patient, their symptoms resolved. The probing duct wasn't going to go away immediately. Like as we know in perio, the probing ducts can take more than just a couple weeks to resolve. So if you want to wait that long, that is technically an option. So if you have a very, very deep probing, like 12 millimeters, but it's a single narrow one, that's something you could wait and look for. So in this case, she didn't, but there was still a little furcation involvement. Okay, that's not too bad, but the symptoms resolved. So because the patient's symptoms resolved and I didn't see confirmatory signs of a vertical root fracture, for example, when I looked into the tooth clinically, I also didn't see a crack or a vertical root fracture. I was then more positive about this prognosis. And so far, this patient is doing well. The shape of this root canal treatment also does show how there were two sides of like an oval shaped distal canal. So there was that missed portion of the distal canal. So that's why it's a little bit wider from this off angle. But nonetheless, the important part is that this tooth still is functional. The patient is aware and has the expectation and understanding that this has a questionable prognosis and we can't completely rule out a vertical root fracture. But so far, we can be cautiously optimistic. Another interesting case where I was pleasantly surprised was also a large lesion mid-root on an existing root canal treatment. I was already very suspicious, super suspicious that it was a vertical root fracture. I did take a Cbct. It looked exactly like this 2D radiograph. Localized radiolucency right at the mid-root. I couldn't see any obvious signs of a vertical root fracture. Both root canal treatments were centered, there was plenty of tooth structure left, and there was still a bony collar in the coronal portion. All pretty good news. So I did again in 2 visits. When in this case, this patient had a sinus tract, so that's why I traced it. That's that piece of gutta percha. I traced it, and it was again straight into the middle of the radiolucency. So I didn't see any confirmatory signs consistent with a vertical root fracture. So again, I told the patient prognosis would be questionable. We would see. So I did the root canal retreatment where I debrided it, placed calcium hydroxide, and evaluated. And this patient had healing of the sinus tract. So when I completed the root canal treatment, I could see that there was actually a lateral canal right into the middle of the radiolucency. So that confirmed that even though this had a lot of signs that could have told me that maybe there was a root fracture, not only could I not visualize one or confirm one, but that radiolucency was almost like a red herring. It's actually due to a lateral canal that just got big enough due to enough bacteria and chronic abscess. And it actually wasn't a vertical root fracture. So because there was healing, patient was now asymptomatic, we could have now a much better prognosis. So right into the middle, very pleasantly surprised. Now, how about restoring teeth that have root canal treatment or cracks? There's a lot of different materials. There's a lot of discussions about post versus no post, biomimetic, hardcore biomimetic dentistry, whether or not there should be cuspal coverage or not, or an onlay, crown lay, that kind of thing. I, as an endodontist, am not here to tell my restorative dentist what kind of restorations to place in, because they know their patient's restorative treatment and their restorative findings, their occlusion. They're checking the full mouth occlusion. They're checking the entire patient's oral health, all that stuff. I'm not here to dictate that, but there's certain recommendations for treating these teeth and restoring these teeth that should be kept in mind. So for one thing, an endocrown, please, for the love of your endodontist, do not place endocrowns unless it's on teeth with very poor restorative prognosis. So teeth with minimal ferrule, guarded restorability, that kind of thing, because endocrowns are meant to be like last resort. Same thing with cast post. The reason is because trying to remove some of these things, especially an endocrown or accessing through an endocrown, is so difficult that it's like a nightmare if it was just done willy-nilly. So don't do that. And additionally, it's best not to place a post in the area of a crack. Other than that, we generally recommend some sort of cuspal coverage to help the cusps not flex so much, but we don't dictate whether it should be full coverage versus like an partial onlay or partial coverage. So the most important things, placing the definitive restoration as soon as possible, because sealing the area up, placing some sort of bonding material and like modern adhesive dentistry is going to help with that as much the most. It's generally preferred if there are concerns about a crack or fracture, not to place a post in that area as well, but having adhesive dentistry protocols instead. Some sort of cuspal coverage, like I said, is preferred because we don't want the cusps to flex away from each other, especially when there are cracks or marginal ridges involved. And then like I said, avoiding the posts in the canals that have a crack. So in this case, for example, I had this patient had some cracks on the distal marginal ridge of number 14. I worked with my restorative dentist, actually not only placing doing the root canal treatment and restorative dentistry in conjunction with each other, but actually we did them the same day. So that way this patient could not only have the tooth bonded and the core buildups placed immediately, but actually the definitive placed as well. Additionally, there may be some considerations instead of a post to use core buildup like feet or like removing a little bit of coronal gutta percha and then placing the bonding material into there to help reinforce it instead of placing a post because the post can flex. Well, some of the considerations in modern like biomimetic dentistry is also to use like ribbon or like fiber reinforced pieces of ribbon. And then most of all, we know that prevention is key. So not only are we evaluating for small cracks right from the beginning, that doesn't mean that teeth with cracks always need a crown, but it's just like looking at the overall patient's occlusion, the existing restorations, and if there are some concerns about cracks already, and especially doing pulpal sensibility testing of teeth for cracks and craze line before larger restorations are placed. So for example, if a crown is going to be placed on a tooth that has an existing crack, it's definitely better to have a pulpal test of that tooth first, some sensibility testing of it to confirm that it's not pulpally involved already before the crown is done. Because we know that a lot of times, especially around these older metallic restorations, these cracks are a lot deeper than we think. So overall, I know it's pretty complicated to not only even just classify cracks and fractures, but also how to detect and diagnose them. But hopefully today you will have gained some tips and tricks and better understanding of not only how to diagnose them, but also evaluating a Cbct to diagnose a possible crack or vertical root fracture. And then also some considerations for both the prognosis, the management, and the overall long-term survival of these teeth. And the biggest takeaway is that J-shaped lesions are not pathognomonic for vertical root fractures or split teeth. So thank you so much, everybody, for tuning in today to my webinar. I know that's a lot of information, so definitely feel free to contact me through my social media platforms or email. So on Instagram, my name is Her Holiness the Pulp. And you can see pictures of my dog as well as additional endodontic education information, and or you can email me specific questions as well. And thank you again to Henry Schein for having me be part of their webinar series in their dental academy.
Awesome. Thank you, Dr. Tran. Always a pleasure to have you. We've got lots of questions, and I'm going to knock out 5 in a row here because they were all the same and they all came in at the exact same time. And that was, what is an endocrown?
Oh, that's a great question. So an endocrown is where the crown and the core buildup are all one unit. So that can either be cast or a lot of times some of the modern ones are like ceric or like all porcelain, or even worse, all zirconia, which is an absolute nightmare to access through. So that's where imagine a cast post or like a cast core if it was part of the crown.
Right, back to the top here. Why don't you recommend ice sticks for cold testing?
So the ice sticks are just so people know, it's like a super old school method. You put water into an old local anesthetic cap and you put it into the freezer.
The thing is that, yes, it's cold, but it has two problems. One is that it's just, freezing point of water, whereas endo ice is actually much colder. If you want to go really cold, you can do carbon dioxide snow, but most people don't do that anymore because it's just way too involved. So the best thing to do is endo ice, or the spray specifically, refrigerant spray or endodiagnostic spray. The reason is because it's much, much, much colder than just the freezing point of water. So it gives you a more accurate test. Secondly, the problem with an ice stick is that it melts. And since it melts, it can flow cold water to multiple teeth and give you an inaccurate test. With the refrigerant spray, the dental diagnostic refrigerant spray, it is localized onto just that pellet. And the main thing to keep in mind is when you place that frozen pellet onto the tooth, because it's very cold, but you want to put it in this cervical area, as cervical as you can, basically on the buccal or lingual of the tooth, not on a cusp and not directly on the occlusal.
Let's see here. What volume for Cbct would you advise for, I guess, just in general, but also all of the cases that you shared?
Oh, okay. So when I'm trying to diagnose very specific endodontic, like where I'm trying to look at the root canal treatment and the existing root canal treatment or existing canal anatomy, it has to be a small field of view. I can't give you exact specific. It's like essentially a sextant. The reason why I don't give the exact dimensions is that it depends on the machine. Each machine has a slightly different definition of what they define as a limited field of view, but basically it's the smallest like quadrant or sextant scan. So you have to look at that on the machine. Additionally, something I've learned is that sometimes it's an additional module you have to download for your machine. Sometimes some machines don't have the capability, like it's specifically built only as a large field of view scan. So like, for example, surgeons, periodontists, if you're placing implants, that kind of thing, they're only buying a large field of view. So that's all they have. They can't do a limited field of view. So it's best to check with your manufacturer to see what your machine options are, as well as if you have to like buy a separate module or download it or whatever.
Can you describe the technique and brand material filling with calcium hydroxide? And secondly, how do you remove that prior to GP fill?
Oh, great question. So there are so many brands. Calcium hydroxide is pretty much the same across all the brands. I think the difference, what you're looking for, is whether or not it has iodide. The iodide, you have to keep in mind if patients have like allergies, that kind of thing. Additionally, the ones with iodide may be a little bit more radio-opaque, which isn't necessarily always what you want, it's depending. Additionally, what you're generally looking for is the liquid calcium hydroxide. So it's like in a syringe. Okay, so you syringe it into the canal system. The reason why I say that is because they also have a powder form. Now, as an endodontist, I love my powder form as well. But the powdered form is a little bit like you have to mix it with water and you have to put it down the canal. Sometimes it's hard to put it down a very, very thin canal, or it's a little bit harder to use, like the texture is a little bit harder. For endo, we use it a lot to soak up really purulent draining teeth, that kind of thing. Or if I want like a really, really firm pack for vital pulp therapy things, that kind of thing, then you'd want a thicker pack. But as a restorative dentist, or just in general, use the liquid form. They have a lot of options. Just don't express it too hard, because if you express it too hard and it goes into vital structures, that's really bad. Your second question, how to remove it: irrigate it out with hypochlorite. So now sometimes it can get stuck in like the isthmuses and stuff. So that's why activating the irrigation solution is going to be helpful. So something like an endo activator, ultrasonic activation, whatever. But in general, irrigating as much as possible will generally remove it, as well as like when you're using your files, it's going to remove it as well.
When should a patient be scheduled for a crown after an endo or retreatment?
So great question. Even though, like I say, restoring it as soon as possible is going to be really important, I also understand that you a lot of times often want to wait until the patient is asymptomatic before you place the crown, because nobody wants to have a patient where none of the patients, of course, want to have it where it is severely painful, still has a sinus tract, anything like that. That's why sometimes I'll do the 2 visits if I'm concerned about a fracture or a crack. That way I can make sure it's healing first. Secondly, that way the patient is asymptomatic by that point. However, since we do want to at least seal the tooth up as much as possible, especially if there is a crack and you're worried about it flexing, at least doing the core buildup part of it. And then if you want to wait for a little bit more resolution of symptoms, that works as well. So one of the things that we're looking for, and when we're doing either in 2 visits or from a restorative standpoint, you're waiting for the patient to be asymptomatic, is after doing at least the prep and temp, because that stops the flexure of the cusps, the temporization of the tooth with the temporary crown, if the patient still is completely symptomatic, like still has symptoms, even with a temporary crown on, unfortunately, the prognosis is not great.
Do you use anesthesia when you do deep probings, or do you suggest?
I don't always, because I want to evaluate all parts of the tooth, like do the sensibility testing, that kind of thing. I really gently probe, as gently as I can. I let the patient know it's going to be a little uncomfortable. If it's completely an issue, then sometimes I will anesthetize after I've done all my sensibility testing. One of the things also too is after, let's say you're getting ready to do root canal treatment, or you're getting ready to do the restorative treatment, do the probing then. Because even though the patient's anesthetized and you're about to do treatment, at least you're finding the deep probing then. So it's good to do a nice full probing again after the patient's anesthetized if you're already going to do treatment.
When there's a small crack line on a marginal ridge, do you recommend opening and filling a proximal box on a composite restoration?
In general, trying to follow the crack line as much as you can, and then so that you're removing that pressure point is going to be very helpful. But follow, of course, your restorative treatment principles in general. Like I said, I'm not here to dictate what my restorative dentists do, so it's, following your normal restorative principles. But yes, if you see a fracture line in general, it's allowing bacteria to get in there and into that crack. So you want to try to follow it as much as possible. Additionally, it can tell you whether or not this tooth is restorable. Like if it's completely going all the way down the tooth, then or has really, really subgingival and associated with a deep probing, then you'd be less inclined to have a good prognosis.
Can the tooth sleuth, is that how you pronounce it?
Yeah.
Can the tooth sleuth be used on a tooth with an existing crown to test for a fracture?
Yes, actually, it's very helpful for that, because even though there's a crown on it, what you're doing is you're localizing the pressure onto a specific cusp, and you're trying to see if there's release pain or pain upon biting. So where what kind of pain there is and when. So it also does help you localize if the pain's on the mesial or distal or where it is. So yeah, it can be done.
All right, we've got lots of questions and we're running out of time. So let's see. How long can good root canals with no PA lesions and very light occlusion have sensitivity to percussion?
So no lesions and
very light occlusion have sensitivity to percussion.
That's a good question. So the lesion in and of itself isn't always necessary to have inflammation. You can have periradicular inflammation or periapical inflammation even without a lesion. So generally, a patient should feel better after root canal treatment and restorative treatment within a few weeks, a few months. Now, let's say I think what the person's trying to get at is patients who are oh, it feels a little different, even though it's out of occlusion, right? And the restorative dentist has adjusted the occlusion 3 times, and it still just feels different. So patients can feel just slight difference for actually months, 6 months to a year. That's not the norm. But letting patients know that it's part of the healing process, because there's always going to be some inflammation as part of the healing process. Plus, because we're dealing with bone and ligaments and lots of things, some people just heal differently than others. Even my own faculty, the chairman of my endodontic program had his root canal treatment done by another, endodontist, well-established, did everything, found all the canals. And he said that his own tooth just felt a little different for a whole year before it got better. I have had patients where it just feels different. They're able to function, they're able to use it, they're able to but it just feels different. So it depends on how extensive the percussion tenderness is. A little bit of tenderness, yeah, it can last for a few weeks, a few months. Where it just feels a little different, but it's not severe, and the patient's able to function on it, it can last for a while. I think that's what they're trying to get at.
All right, we're going to go one more question, and maybe it'll make you think a little bit here. Tooth 18 with a DMR fracture, visible extending to gingiva, minimal probing, and is asymptomatic. Should you place full coverage crown now or wait until the patient has symptoms? And when symptomatic, do you do an endo treatment now or a crown?
Wow. Okay. So the question is the tooth, so it's tooth number 18, second molar, has distal marginal ridge fracture. It's visible, extends to the gingiva, but doesn't have any probing. So, okay, that could be like a normal tooth that has an existing restoration. Like we see that a lot in old amalgam restorations. Should you place the full coverage crown now or wait until the patient has symptoms? If you see the fracture and is the restoration having issues? Is there recurrent caries? A lot of times there is. If you're seeing a fracture like that, then maybe, yes, you would consider some sort of cuspal coverage or a new restoration. It depends. If there's caries, you should do a new restoration. If the existing restoration is like really wide and it's like really thin remaining tooth structure, then you may want to consider cuspal coverage, not this crown or crown layer, whatever. It depends on you guys. And then should you wait until the patient has symptoms? You shouldn't really wait for a patient to have symptoms if you can see that there's some sort of restorative problem. It depends on what the restorative problem is. Is there caries? Is there a lot of fractures? Is it leaking restoration? That kind of thing. And if the patient has, what's it called? And then you should test the tooth for endodontic involvement ahead of time. So anytime you see some sort of fracture and it's kind of deep, or you see crack lines around this tooth, it doesn't hurt, especially if the restoration is deep or the crack is deep, to see if there is irreversible pulpitis. If the tooth's vital, no lingering pain, do the restoration, see how it goes. If the patient has symptoms after, then you would need endodontic treatment and then consider cuspal coverage. That's the process.
We got further clarification that it would be a virgin tooth 18.
So virgin tooth. Oh, virgin tooth, and there's a crack on it. I mean, then you might be concerned about what's going on in that tooth, why there's a crack. Depends on if it's a craze line versus a crack that goes all the way down the gingiva. It depends. We're not saying on a restorative dentist, you don't restore every craze line there is. So it depends on what the pulpal involvement and the restorative involvement is.
Cool. All right. There was one more question that came in that I want to ask.
Okay.
Does symptomatic release of pressure with a tooth sleuth indicate a fracture tooth with pulpal involvement?
It's two different things. So pulpal involvement is based on the hot and cold sensibility test. So if it's responding to cold or not, and if there's lingering pain to cold or not. The symptomatic release of pressure on a tooth sleuth, if there's pain on release of the tooth sleuth, it can tell you if there is a larger fracture, because it's like the pieces like coming back together that are having pain. It's not like definitive of a crack versus a fracture, but it tells you something. It tells you another piece of the puzzle. Additionally, what you're looking for is pain on like specific areas of the specific cusps, or if it's a specific side, or if it's like both sides, like if it's medial and distal. So it's it can tell you if there's a fracture or a crack, and it can, but the pulpal involvement is separate. It doesn't tell you that there's pulpal involvement. These separate things.
All right. On your next webinar, I think we have to play Try to Stump Dr. Tran.
It depends. A lot of times the answer, it's just like, but yeah.
Cool. Well, thank you everyone for the questions, and especially to those of you on the East Coast sticking with us late here tonight. We appreciate it. If there were any questions that were asked that we did not get around to answering, please feel free to email Dr. Tran directly. Go give her a follow on Instagram, or you can email us at webinars@henryschein.com and we'll route your question accordingly. Tonight's webinar was recorded, so we'll shoot that out to you within a week of tonight. And if you're interested in any future Henry Schein webinars, visit henryscheindental.com/webinars for our upcoming schedule. Dr. Tran, thank you. Always a pleasure. And thanks everyone else for joining. Have a great night.
Thank you so much, everyone. And thank you, Henry Schein.